this noontime. Now it's 12 o'clock. Good noon, ladies and gentlemen. Welcome to the APSC Cloud Forum of Cardiovascular Disease. Today, we are going to share an important topic about the deep thinking in timing and the candidate for interventional treatment of severe valvular heart disease. Today, we will focus on mainly the mitral valve and tricuspid valve. And I think with the aging, I think that in addition to the current atherosclerotic heart disease, degenerative valvular heart disease in structural heart with often severe heart failure have emerged as a new medical burden in societies with growing aging population. Deterioration of degenerative mitral regurgitation with atrial cardiac damage, critical secondary mitral regurgitation in medically resistant heart failure, reduced ejection fraction, and atrial fibrillation related atrial functional mitral regurgitation, and the intractable tricuspid regurgitation in structural heart disease are now new topics to be discussed and expected with novel resolution by leading cardiac imaging specialists, medical and surgical interventionalists in the first of the webinar series focusing on severe valvular heart disease. Today, we have two chairpersons. The first will be Dr. Mungunchimeg, and the second chairperson will be Dr. Chung-Lieh Huang. I'm Dr. Chung-Lieh Huang from McKay Memorial Hospital, Taiwan. And due to emergent health issues, Dr. Mungun will not be absent this week, but she will appear next week to continue our webinar for ongoing programs. For the first speaker, it's my pleasure and honor to invite Dr. Adisai Buakhamsri to give a talk. Dr. Adisai is currently an associate professor at the Department of Medicine and Faculty of Medicine at Thammasat University, Thailand. He is expertise in echocardiography and currently the stay in the main field of echocardiography, the laboratory and heart failure clinic, and also currently the lead of cardiovascular imaging in the Thammasat Heart Center and University Hospital in Thailand. He's going to share with us about the critical timing and the candidate of surgical treatment in severe primary degenerative mitral regurgitation, about a decision by MR severity alone or by mitral cardiac damage. Dr. Adisai, please.
Thank you very much, Dr. Huang, and good morning from Thailand. Actually, it's a good noon somewhere else, and I would like to say hi to all the panelists today. And I would like to share my my video. Hello, good morning. My name is Adisai Buakhamsri. I am an associate professor in cardiovascular medicine, Thammasat University, Thailand, and also I am the representative of the Heart Association of Thailand. My talk is entitled as Critical Timing and Candidates for Surgical Treatment in Severe Primary Degenerative Mitral Regurgitation, Decision by MR Severity Alone or Extramitral Cardiac Damage. I have no conflict of interest related to this talk. My talk will cover on only primary degenerative MR. I will be talking about the recommendation on valve intervention in primary degenerative MR from both the American and European guidelines. I will touch on assessment of valve severity by echocardiogram. Is this adequate too? And then I will show you the importance of extramitral cardiac involvement in degenerative MR, what are prognosis factors, and their clinical impact on patient survival. Let's go to the 2020 ACC AHA guidelines for management of the valvular heart disease. It has an algorithm for intervention in primary MR. It starts with the degree of the MR that should be severe based on the echocardiographic parameter, vena contracta more than 7, regurgitant volume more than 60, regurgitant fraction 50, and importantly, effective regurgitant orifice more than 40. If the patient with severe MR is symptomatic, such as having dyspnea on exertion or worsening functional capacity, this is the class 1 recommendation for valve intervention. If there is a LV systolic dysfunction, such as LVEF less than 60% or LV end systolic diameter more than 40, valve intervention is also recommended. Although this guideline has mentioned on the presence of RV systolic dysfunction, pulmonary hypertension, impaired LV global longitudinal strain, and elevated BNP as a caution for consideration of the valve intervention. However, these are not currently incorporated into the algorithm. LV global longitudinal strain at rest or during stress test performed better than LVEF in detection of a subtle LV systolic dysfunction. However, application into the practice is still limited. And how about the more recent 2020 ESC-EACTS guidelines on valvular heart management? Severe MR and the symptom or the presence of LV systolic dysfunction are required to proceed to valve intervention. This is the class 1 recommendation, which is similar to those of the ACC/AHA guidelines. An obvious difference is new onset of the AF, the presence of the pulmonary hypertension, and the LA dilation, which are included in decision pathway of the ESC guidelines. In addition, possibility of successful valve intervention, if to be performed, should be considered. Valve anatomy and the surgical skill of the center are important factors. If surgical or edge-to-edge repair is planned, it should be certain that pre-procedure anatomy as well as surgical experience are fulfilled, since the residual MR after the procedure is associated with adverse long-term outcome. This is a summary table for recommendation of valve intervention and the corresponding level of evidence from the ESC 2021. Is the echocardiographic valve severity an adequate tool? This was a study of almost 4,000 patients with degenerative MR. The authors have demonstrated the relationship between echocardiographic effective regurgitant orifice and the risk of mortality in this large cohort. On the left side, with effective regurgitant orifice area less than 20, normal survival under medical treatment, you can see the green zone is noted. For effective regurgitant orifice area more than 20, excess mortality is not only related to severe MR, it also appears the same with the moderate effective orifice area, and become notable when effective regurgitant orifice is more than 30. In the severe MR range or ERO more than 40, individual ERO values have essential information additional to MR grade. ERO provides incremental prognostic precision regarding excess mortality risk. This pattern was also observed with the regurgitant volume. Clinical factors other than effective regurgitant orifice also affects the prognosis of patients with degenerative mitral regurgitation. The MIDA registry, or Mitral Regurgitation International Database, which included more than 3,600 patients with degenerative MR. This study has shown that other than effective regurgitant orifice, LV dimensions, and LVEF, factors such as presence of atrial fibrillation, left atrial diameter, and RV systolic pressure all were associated with the worsening prognosis in patients with degenerative MR. Points were assigned to each of these factors, and the MIDAS score was then obtained. The higher the score, the worse the prognosis. This was independent of effective regurgitant orifice or severe grade of MR. It should be noted that LA size and the presence of atrial fibrillation are significant markers of the prognosis. MIDAS score, which incorporates extramitral cardiac involvement, can predict mortality risk of patients with degenerative MR, whether they receive medical therapy or receive mitral valve surgery. Recently, the researchers from two heart centers in Leiden, the Netherlands, and Italy have just published a retrospective study in JACC cardiovascular imaging. The aim was to evaluate the prognostic impact of extramitral cardiac involvement, with all-cause mortality as the outcome. Patients included in this study has primary degenerative mitral regurgitation with moderate to severe or severe degree of MR. All patients underwent mitral valve surgery. The researcher categorized the patient into 5 subgroups according to extramitral cardiac involvement, as determined by echocardiographic parameters. For the group 1, with LV involvement, such as LV dilation or reduction of the LVEF less than 60%. Group 2, left atrial involvement with LA diameter more than 55 or the presence of the atrial fibrillation. Group 3, pulmonary vasculature. The patient may have a systolic PA, systolic pressure more than 50, or having tricuspid regurgitation more than grade 2 plus. Group 4, having RV involvement with a TAPSE less than 17 mm. Patients who had no extramitral cardiac involvement were allocated to Group 0. 1,106 patients were included with a median follow-up of 88 months, or around 7 years after mitral valve surgery. Most of the patients were symptomatic at baseline. There were significant differences in survival between groups, where the worst outcome occurred in Group 4, which included patients with RV systolic dysfunction. For patients in Group 2, 3, 4, or in other words, those patients having involvement of the left atrium, pulmonary vasculature, tricuspid valve, or RV dysfunction, had poorer prognosis than those who had only LV involvement. It should be noted that patients with dilated left atrium or presence of the atrial fibrillation had a similar prognosis as patients who had pulmonary hypertension. This emphasized the important impact of the left atrial size on the prognosis of degenerative mitral regurgitation. This figure summarizes the prognostic impact of extramitral cardiac involvement on all-cause mortality from this study. The new classification system that I just presented to you, using simple extramitral echocardiographic parameters, may help refine risk stratification and the timing of surgery in patients with primary degenerative mitral regurgitation. All data that I have just mentioned in the previous slides have strongly supported LA size and RV function as parameters that must be assessed when dealing with every single patient with degenerative mitral regurgitation. Another recent published study thus involving assessment of left atrial function using echocardiographic measurement of left atrial strain by speckle tracking echocardiogram. They performed in patients with primary as well as secondary mitral regurgitation compared to healthy subjects. Exercise stress echo and cardiopulmonary exercise test or CPET were performed. Left atrial strain on the left, the higher the better, represent left atrial reservoir function. On the right, left atrial strain rate, the more negative the better, represent left atrial pump function. Patients with mitral regurgitation had impaired reservoir function and pump function. The more severe mitral regurgitation, the worse function of the left atrium, whether it is the primary or the secondary MR. In the setting of severe mitral regurgitation from the same study, the ability to augment left atrial reservoir capacity and booster pump function becomes very critical for preserving cardiac filling and cardiac output. Right ventricle and pulmonary artery coupling you can see on the right side. It was impaired with mitral regurgitation and the presence of the left atrial dysfunction. The last one, this is an example case. The patient is a 70 years old man who is a known case of a degenerative mitral regurgitation diagnosed 2 years ago and has been regularly followed. Now he is on NYHA functional class 2. Echocardiogram, as you can see, it revealed moderately enlarged left ventricle with eccentric LVH. LVEF is around 65%. The mitral valve leaflets are myxomatous with visible flail P2 segment and a severe mitral regurgitation. Effective regurgitant orifice is calculated as 35. Regurgitant volume is 50. Regurgitant fraction of 45% with the systolic pulmonary vein flow reversal, as you can see on the right upper panel. Although all echocardiographic parameters are not completely fulfilled for diagnosis of severe degree of the mitral regurgitation, his symptom is very, very concerned. Importantly, the left atrium is severely enlarged. There are multiple evidence of the increased pulmonary pressure, as shown by the very high TRPG of 80. The systolic D shape of the interventricular septum from the short axis mitral valve view. Calculated mean PA pressure was at least 35 mm mercury with a very short PV acceleration time of only 49 milliseconds. The tricuspid valve is quite mild. However, the RV systolic function is very obvious. As you can see, the RV contraction is markedly reduced. The RV-FAC is only 18% and the TAPSE is only 1.5 centimeter. Both the FAC and the TAPSE are supportive of the RV systolic dysfunction. This is the representative case of severe degenerative mitral regurgitation with multiple extramitral cardiac involvement. The prognosis of this patient is quite poor without mitral valve intervention. However, In this case, after discussion with the patient, and also I brought this case to the heart team. The surgical mitral repair was then performed with a successful result. In conclusion, for the patient with degenerative mitral regurgitation, the proper risk stratification and the timely indication for surgery remain a clinical challenge. The presence of atrial fibrillation, severe left atrial enlargement, pulmonary hypertension, and the presence of RV systolic dysfunction were independently associated with the all-cause mortality. Anatomical and functional extent of extramitral cardiac involvement have a very, very significant impact on the patient's survival. Thank you for your attention.
We thank Professor Adisai for very interesting and important topic, sharing the concept of extramitral markers in the prognostic impact of degenerative mitral regurgitation. And we welcome some questions from the panelists and from all the audience. And the whole program will be monitored and supervised by Professor Chung-Lieh. And welcome Q&A. We have about 5 minutes for some questions for Professor Adisai.
Thank you.
I think I would like to propose the first question. Okay, Professor Adisai, as in your speech, we saw beautiful data and some important new concept about the extramitral cardiac damage markers. And to you, in your clinical experience, which marker, single marker alone, would represent the highest wave or the prognostic surrogate marker for all these different variables or parameters observed or proposed? That is my question. As we know that all the clinical doctors are very busy, and we are looking for a lot of informative data from the echocardiogram. But maybe you can propose one or two most important key markers for all our clinicians. Thank you.
Thank you. This is a very good question, because we would like to know if we have a one parameter, which one is the best? Actually, I don't have I don't know the correct answer, but actually from the data that I just presented in the previous lecture, I think that the RV function is very important, because I think that this is the anatomical position of the RV. It's kind of the very, very late anatomy that will affect by the mitral regurgitation. So it means that whenever the patient who has a mitral regurgitation having the RV systolic dysfunction, the prognosis is very poor, because you can have a RV systolic dysfunction when you have a pulmonary hypertension. So that's why the RV function may be the best parameter for the prognosticator in this case. But in our practice, we don't want to see the patient who have a mitral regurgitation develop a RV systolic dysfunction. So I think that for the clinical, point, the important clinical point, you need to detect a very early stage of the extramitral cardiac damage before the RV systolic dysfunction develop. So I think that if we want to see what is the better parameter, I think the size of the left atrium may be very interesting. Yeah. But you need a very high cutoff point for the left atrial size to see whether extra cardiac involvement of the mitral regurgitation happen or not, because most of the patients who have mitral regurgitation always have the big left atrium. But the cut point, I think that it would be more than if you follow the MIDA registry or another study from Leiden University, they use the cutoff point of the left atrial volume index more than 60. So it's quite big. Yeah.
Thank you, Professor Adisai,
Thank you
for the wonderful and important response. And we look forward to other questions from all the panelists and the audience and the participants. So actually, I have another question for Professor Adisai. Is about the right ventricular dysfunction. And I agree that right ventricular dysfunction is important in the prognostic impact. And what kind of RV dysfunction parameter would you recommend? We know that APSC or right ventricular fractional area shortening or even RV strength are popularly used and widely applied. And which one would you recommend in your daily practice? Thank you.
For my daily practice, I usually use the TAPSE as also the RVFAC. And right now, I think that it's quite easy to obtain the RV strain. So it's kind of a routine measurement in most of my practice. So when we have the patient who have a severe mitral regurgitation, we usually obtain the RV focus view, and then we will measure for the RV global longitudinal strain for the free wall. So I think that we need to use multiple parameters to confirm whether the patient have a RV systolic dysfunction or not, because the TAPSE is kind of a load dependent. So sometimes TAPSE maybe appear quite normal, but the RVFAC or the RV strain may be significantly reduced. So I think that we need to use a multiple parameter for RV assessment.
Thank you, Professor Adisai. And we welcome the participant or panelists to raise their questions through the chat function or just go through directly. And I think if there is currently no more questions for Professor Adisai, I think due to the time constraint, we will move on to the next speaker. And I would like to introduce Professor, I think I'm going to Sunjin Park, Professor and the Director of Cardiovascular Imaging Center and in the Department of Medicine, Division of Cardiology and the Heart Vascular Stroke Institute. Today, Professor Sunjin Park is going to share with us about an important topic about the critical timing and the candidate of surgical or transcatheter treatment for secondary mitral regurgitation in heart failure with reduced ejection fraction, and the decision by EROA and regurgitant volume co-apt or mitral FR criteria. Professor Sunjin Park, please.
Thank you. It's a great honor to join this session. My name is Sungjin Park from Samsung Medical Center. Today's my talk is about critical timing and candidate of surgical transcatheter treatment for secondary mitral regurgitation in heart failure with reduced ejection fraction. Decision by EROA, regurgitant volume, co-apt, or mitral FR criteria. Next 20 minutes, I'm gonna talk about as below. Secondary functional mitral regurgitation were developed in ischemic or non-ischemic LV dysfunction caused by tethering and incomplete closure of normal mitral valve leaflet. However, until now, when is the optimal timing for intervention? Which parameter is important for the selection of optimal timing? The severity of mitral regurgitation, progressive ventricular dysfunction, ventricular dilatation or worsening symptoms. We didn't know that. However, recently, Mitral FR trial and COAP trial might give the answer about this question. The result of Mitral FR trial and COAP trial showed the opposite. In Mitral FR trial, non-significant difference in mortality and heart failure hospitalization between optimal medical therapy and mitral clip. However, in COAP trial, mitral clip group reduced not only heart failure hospitalization, but also all-cause mortality, all-cause and cardiac mortality. So what is happened? After that, so many articles addressed what is the main reason and what is the cause and about the diabetically opposite result. We think about that is what it has happened. One is mitral FR enrolled patient with less severe MR than COAP trial. As you already know that mitral FR trial included the severe mitral regurgitation by the ESC guideline, previous ESC guideline, EROA larger than 0.2 or regurgitation volume larger than 30 milliliter. So mean EROA number was 0.31, less than COAP trial patient, and moderate mitral regurgitation patient was included 52%. However, in COAP trial, severe mitral regurgitation definition was used the USA guideline. So moderate mitral regurgitation patients were included only 14%. And number two is the mitral FR likely had more patients with less recovered LV compared with COAP. So LV and the systolic dimension larger than 70 millimeter. So those patients were included in mitral FR. However, COAP trial did not include those patients. So mean LV and the diastolic dimension were larger in mitral FR trial compared to COAP trial. Also, LV end-diastolic volume and end-diastolic volume index. Number three is the maximal dose of GDMT was more strictly evaluated than enforced in COAP trial. So COAP trial patients might have been more selected in node, while mitral FR in node more on selected functional mitral regurgitation patient. So it's the maximal dose of GDMT was important. This slide showed. After that is the new conceptual framework that reconsidered the result of the mitral FR and COAP trial. What happened is this new conceptual framework about the proportionate and disproportionate functional mitral regurgitation. Why a new conceptual framework is needed? Classic framework as below. Primary mitral regurgitation benefited from the mitral valve replacement or repair. Functional mitral regurgitation did not respond favorably to mitral valve surgery. However, those classic framework ignored the fact that the mitral valve consisted not only of the leaflet, but the entire supporting apparatus, which included annulus, chordal, and papillary muscle. So this slide shows the theoretical relation of mitral regurgitation severity to LV size in functional mitral regurgitation. Theoretically, EROA or regurgitated volume increased in proportion to LV and diastolic volume. However, the disparity between LV size and MR severity were developed commonly. Those are caused, number one, balance between reduced closing or increased tethering pulse. So imbalance tethering pulse and closing pulse. And number two is the natural variation in length area of mitral leaflet. So is the length or area of mitral leaflet are different in those patients. And number three is the augmentation of anterior mitral leaflet. Levin showed some data in animal study. Number 4 is the hemodynamic status or volume status, and MR is dynamic. The number 5 is the focal wall motion abnormality causing severe tethering and severe mitral regurgitation. So this slide shows the representative case of proportionate MR and disproportionate MR. The proportionate MR is that the magnitude of mitral regurgitation is related to the LV and diastolic volume. Symmetrical displacement of the papillary muscle equals tethering of the mitral regurgitation. So the increase the LV proportionally increase the mitral regurgitation. However, disproportionate mitral regurgitation, the magnitude of mitral regurgitation exceeds the associated with LV and diastolic volume. So smaller LV and diastolic volume, larger mitral regurgitation. Those situations were developed LVBB or impero-posterior mitral impact, papillary muscle in equally displacement or discoordinated activation, asymmetrical mitral valve closure, so developed disproportionate mitral regurgitation. How about the guideline? Current guideline do not identify the causal MR mechanism. Current guidelines do not distinguish between these two types of functional mitral regurgitation. So eccentric or central, or is the disproportionate or proportionate mitral regurgitation in patients with coexisting mitral LV disease. Focus solely on quantification of the severity of mitral regurgitation rather than elucidation of the underlying mechanism. This graph shows the USA guideline, and this shows the current revised APSC guideline for the management of valvular disease. And primary mitral regurgitation and secondary mitral regurgitation use the same criteria, ERO 0.4 and regurgitated volume larger than 60 milliliter. However, this guideline did not distinguish several mechanisms in functional mitral regurgitation. Also, 2021 APSC guideline for the diagnosis and treatment of the acute and chronic heart failure. This slide shows the management of second mitral regurgitation in patients with heart left patient. Number 1 is the heart team evaluation. And we assess the need for coronary revascularization and OMT, including CRT, if indicated. Yes or no, that time is the persistent of heart failure symptom and significant serious mitral regurgitation and heart team re-evaluation. After that, echocardiographic and critical criteria for outcome improvement after percutaneous edge-to-edge mitral valve repair. Yes, that time is the class 2A indication. We should perform the transcatheter edge-to-edge mitral valve repair. Also, we importantly consider to this box, all of the following criteria must be fulfilled. LV ejection fraction 20 to 50%, LV and systolic demand less than 70 millimeter, coincident, same as the Atrial result. Systolic pulmonary pressure less than 70 millimeter mercury, absence of moderate or severe RV dysfunction or severe TR, absence of hemodynamic instability. So we also consider what is the exact definition of severe secondary mitral regurgitation. Guideline suggested or focused integrated approach. However, this is not simple, so we did not use those several criteria in clinical field. However, it's the functional mitral regurgitation has so different feature. Same EROA and same regurgitated volume and same LV and diastolic volume, the relationship is very different. And we check the normalized regurgitant volume. Regurgitant volume divided LV and diastolic volume. This concept is maybe developed is what is the difference between secondary mitral regurgitation and primary mitral regurgitation. In severe secondary mitral regurgitation, regurgitant volume divided and diastolic volume was 0.50. LV enlargement that is disproportionate to what might be expected from MR alone is the dose parameter regurgitant volume divided the LV and diastolic volume 0.15 is less than 20% is the characteristic of the secondary mitral regurgitation. However, in primary mitral regurgitation, the regurgitant volume divided the LV and diastolic volume is substantially higher. For example, is the 20%, more than 20%. So in those new concept is the average data from the published study of patient with chronic mitral regurgitation. Blue box is the primary mitral regurgitation, red box is the secondary mitral regurgitation. And primary mitral regurgitation is larger than 20%, and functional mitral regurgitation less than 20%. And this graph shows the same result. However, the COAP trial and mitral trial. COAP trial is the 0.15 and mitral trial 0.18%. So we did not distinguish exactly a COAP patient and mitral FR patient using by the regurgitant volume divided LV and diastolic volume dose concept. So we consider the quantification of mitral regurgitation is that we use the PISA and stroke volume method. The PISA has the way larger advantage. However, it's the several people, as you know already, and the stroke volume method also is the advantage and is the large people. However, the guidelines show the error of 10% and 25% uncommon even among the expert leaders developed in PISA evaluation. So also the PISA has the several advantages. However, the dose parameters are very, very inter-observer and intra-observer variability. We consider the PISA method and stroke volume method, and EROA is the regurgitant volume divided VTI. Regurgitant volume equal is the LV and diastolic volume multiply LV ejection fraction multiply regurgitant fraction. So EROA is the regurgitant LV and diastolic volume multiply LV ejection fraction multiply regurgitant fraction divided LV TVI. So EROA dependence on LV and diastolic volume. Also, regurgitant volume dependence on LV and diastolic volume. So second new concept is the EROA divided the LV and diastolic volume. So disproportionate versus proportionate severe functional mitral regurgitation, we use this new concept as the MR dominant group is the COAP trial patient, and is the LV dominant group is the mitral FR patient. So EROA divided the LV and diastolic volume is a COAP patient is those patient inserted in this color box, and is the mitral FR patient was suited in the green box. And COAP trial patient were divided, the subgroup is the 6 equally sized subgroup. That time is the only one group, except only one group. The other group is the totally situated in is the those in color box. So EROA divided LV and diastolic volume. We used this criteria. Proportionate and disproportionate mitral regurgitation were classified very well. So is this MR dominant disproportionate severe mitral regurgitation patient is the treatment plan is the direct reduction of effective regurgitant orifice area. However, Those patients is MR and LV co-dominant proportionate severe mitral regurgitation. Treatment plan is same as proportionate MR. A proportionate patient selection for mitral clip in severe functional mitral regurgitation. Which patient is which patient in COAP trial patient and which patient in mitral FR patient? We didn't know that, but we assessed the integrated approach and is the new conceptual parameter for evaluation of patient selection. Unresolved question is that is the significant tricuspid regurgitation and markedly elevated pulmonary artery pressure. Those patients prior mitral clip trial did not enroll. So we didn't know that patient with significant TR and elevated pulmonary artery pressure. Also, acute mitral regurgitation, we have the limited experience. I showed the one case of in my hospital, and one case is the 76 years old female. She was hospitalized for dyspnea with NIH functional class 4. TCMP was diagnosed 3 years ago under GDMT. Ischemic stroke 1 year ago. NT-proBNP level is 3,499. ECG showed the atrial fibrillation in wide QRS, and chest PA showed the pulmonary congestion and cardiomegaly. And this slide showed this patient echocardiography. LV and diastolic dimension 75, systolic dimension 63, and severe mitral regurgitation showed. And LV ejection fraction 29%, and ERO 15.7, and regurgitated volume in 55. How about this concept? Regurgitated volume divided LV and diastolic volume. Regurgitated volume 55, LV and diastolic volume 230, divided ratio is 0.24. So this patient is the end. So this criteria show the not candidate for the functional mitral regurgitation. However, the other new concept, EROA divided LV and diastolic volume, EROA 57 and diastolic volume 2,230, and those patients treated in a COAP trial patient. So disproportionate severe functional mitral regurgitation patient. So we check the transesophageal echo, and main jet was developed in A2P2 portion. We performed the transcatheter H2H repair. First clip implanted A2P2 level, and it's the second clip implanted and beside the first clip. This is the final result. And NT-proBNP level was decreased to 2045, and chest PA showed the decreased heart size and improved pulmonary congestion. Also is the transthoracic echo immediate after TR, and LV, still LV was enlarged and LV ejection fraction was severely decreased. However, the patient's symptom was very much improved. So the end of my lecture take-home message was that severe functional mitral regurgitation in heart failure reduced ejection fraction, despite maximally tolerated GDMT, symptomatic, moderate to severe or severe functional mitral regurgitation, LV ejection fraction 20% to 50%, and LV and systolic dimension less than 70 millimeter via multidisciplinary heart team approach. This patient also same as the disproportionate functional mitral regurgitation included in co-trial patient. So when you look at the patient with severe functional mitral regurgitation in heart left patient, the time is we look at the mitral regurgitation severity and LV ejection fraction. Also is this patient co-trial patient or mitral FR patient, we look at the multidisciplinary heart team approach and integrated approach, and finally we selected the TIO is better or is the medical therapy is better. Thank you for your attention.
Thank you, Professor Park, for your wonderful share and speech. I think this is very important topic, and now it's time for open question and Q&A. And whether there will be any questions for Professor Park from our panelists or from all our audience of participants. I have a question for, actually I have two questions. Please allow me to have two questions for Professor Park. I think as for a famous professor and scholar, Professor Park provided important concepts, right, about the selection of mitral clip patient population. And I am wondering whether you are going to do this, or you are doing this all of the workflow for your daily practice in those patients for suitable as a candidate for mitral clip. And also, I'm wondering, as you mentioned, the mitral FR and COAPT has different criteria. And also we know that there would be functional MR and the primary MR. Do you propose different criteria for these two different conditions in your daily practice? And did you do that routinely in your daily practice? And the second question would be, if a patient is also suitable for cardiac CRT, resynchronization therapy, would you propose to have CRT first and then go to mitral clip if the patient is supposed to have very poor LV function, or you suggest inversely? This is my question, and maybe Professor Park can provide us some comment.
Thank you for your important question. And the first question is when you look at the patient, the candidate for mitral clip is we check the severity of mitral regurgitation, and is this patient mitral regurgitation is proportionate or disproportionate. We use those concept because it's after the mitral clip, some patient improved the outcome, but the other patient did not improve LV function. So, which is the important prognostic factor for improvement outcome after TR. This is the important. So we check the severity of mitral regurgitation, and it's the LV size and LV function. Also, disproportionate and disproportionate mitral regurgitation criteria. And it's the most of that is the most important thing is the anatomically candidate for TR. Yeah, that is the important. And your second question is the criteria and definition of functional MR and secondary MR. Previously, ESC guideline used the different criteria as the help of the functional help of the primary MR, and the functional MR definition of functional MR help of the primary MR. But recently released 2021 Valvular is the ESS guideline used the same criteria. So is the primary MR is the functional MR, also ERO 40 and regarded volume 60 milliliter. So in our hospital, we use the same criteria in functional and primary mitral regurgitation. And is the other question is if the patient the candidate for CRT is the CRT first or mitral clip first. So is the technically CR in perform the CRT patient is the TO is a little bit difficult. Yeah, but is the But guidelines suggested if the patient candidate for CRT first. After that is the LV function did not improve after we consider the TEER. So in our hospital also follow those guidelines.
Thank you, Professor Park, for your comment and response. And I'm wondering whether Professor Adisai would give us also some comment. Okay, if not, I think it's time to move on to the next session due to the time constraint. And I think I would like to introduce the next speaker as Dr. Kuan-Chih Huang. Dr. Huang is a famous clinical doctor from Taiwan. And actually, I think he has important work about the artificial intelligence in cardiovascular imaging. Also, he did a lot of key imaging in clinical practice. So I think he is the right person to give us a talk and share about the topic about the atrial functional mitral regurgitation in atrial fibrillation and the heart failure with preserved ejection fraction, and how important is it? Dr. Huang, please.
Can everyone hear me? I mute myself.
Yes.
Okay. So thank you for your nice introduction, Professor Huang. And dear everyone, I'm Casey Huang from National Taiwan University Hospital, Hsinchu branch. And I really appreciate Professor Lin to giving me this great opportunity to give a talk about atrial functional MR. Heart failure with preserved ejection fraction and atrial fibrillation, once called a vicious twin. They have both high prevalence in each other, and they shared common risk factors such as hypertension, aging, obesity, and they also have similar pathophysiology, including systemic inflammation, upregulation of RA system, endothelial dysfunction, and the depletion of atrial natriuretic peptide. Both HFpEF and atrial fibrillation can cause mitral annular dilatation, decreased mitral annular dynamics, and imbalance of annulus area and the leaflet area. All these mechanisms contribute to atrial functional MR. So why is it important? In the ATTEND registry, as reported by Dr. Kajimoto, even mild MR at discharge was linked to worse outcome in HFpEF. In patients with concomitant atrial fibrillation and preserved LVEF, the presence of more than moderate MR had a higher event rate in terms of cardiac death and heart failure hospitalization. Although might be underestimated because the current guideline did not think atrial functional MR as an isolated entity. However, the prevalence of significant atrial function MR is about 7% in patients with atrial fibrillation, and is around 18% in patients of heart failure with preserved EF. Annular dilatation usually reminds physicians of the Carpentier type 1 MR. However, a compensatory leaflet growth can compensate the functional MR. As you can see,
9A 张志光先生的家属，请至东指示楼恢复室。9A 张志光先生的家属，请自东指示楼恢复
As you
室。
can see, the mitral leaf area significantly expand in a sheep animal experience with functional MR created by stretching the papillary muscle down toward the apex. Similar phenomenon is also observed in patients with chronic aortic regurgitation. Dr. Kim defined inadequate leaflet growth as the ratio of total leaflet area to annular area is less than 1.5, and the atrial functional MR will develop thereafter. As you can see, these two patients are of similar annular area, around 600 square millimeter. But patient of a severe atrial function MR has smaller total leaflet area and thus lower total leaflet area to annulus area ratio. Mitral annulus dynamics is far more complex than what we can imagine. There's the threefold annular motion during systole, including antero-posterior contraction, increase of annular height, and the saddle shape of mitral annulus, and the translational motion. With the advance of 3D technology, this delicate annular motion nowadays can be observed after 3D spherical tracking of the mitral valve. We can measure the antero-posterior diameter, the intercommissural width, the annular height, and the non-planarity angle, which stands for the saddle shape of mitral annulus. Dr. Different conducted an observational study to compare the temporal change of 3D structure of mitral annulus before and after electrical cardioversion of atrial fibrillation. Restoration of sinus rhythm can increase the annular contraction. As you can see from the blue line, is the follow-up TE data after cardioversion. And the restoration of sinus rhythm can also help mitral annulus regain its saddle shape. As you can see, there is more dynamic change of non-planarity angle during the cardiac cycle and a higher annular height over intercommissural width ratio. In a 3D study comparing atrial functional MR and the ventricular functional MR, atrial functional MR is of more severe inadequate leaflet growth. On the other hand, ventricular functional MR is of more valvular tenting area, tenting height, and more subvalvular leaflet tethering. Because of these different mechanisms, ventricular functional MR usually present with an eccentric MR jet, and the atrial functional MR usually present with a central MR jet. However, when there is significant dilatation of left atrium and the mitral annulus, the posterior mitral annulus, the P point, will deviate toward the outside of myocardium and causing the tethering of posterior leaflet. As you can see, when the P point migrates outside the myocardium, the PML angle is more steeper, and this will cause eccentric atrial functional MR. And the least type of atrial functional MR is of even worse clinical outcome. Surprisingly, atrial functional MR can have even worse prognosis than primary MR. In a TEE-based mitral valve evaluation, retrospectively conducted in Cleveland Clinic, there were 22,000 TEE from 2011 to 18, and around 500 severe MR with no more LVEF were identified. After excluding prior mitral surgery, endocarditis, hypertrophic cardiomyopathy, restrictive cardiomyopathy, constrictive pericarditis, and the duplicate patients, 41 severe atrial functional MR and 244 patients with severe primary MR included for analysis. As you can see, atrial functional MR had more comorbidities such as persistent or permanent atrial fibrillation, more hypertension, more diabetes mellitus, more pacemaker, and more prior non-mitral cardiac surgery. As mentioned by Professor Adisai in the previous talk, right heart dysfunction will lead to a worse prognosis. And as you can see, atrial functional MR has larger right atrium size, more dilated right ventricle, and elevated right ventricular systolic pressure, even at lower EROA. On Kaplan-Meier analysis, survival analysis, patients with atrial functional MR compared to primary MR had a significantly worse survival and more heart failure hospitalization. After understanding the importance of atrial functional MR, however, there's a lack of evidence in the management. Besides risk factor and the lifestyle adjustment for AFib and the HFpEF, and the symptom-based control and titration with diuretics, sinus restoration seems reasonable, but actually not every atrial functional MR has an atrial fibrillation. On the other hand, there is limited evidence to support surgical or transcatheter mitral intervention in the current stage. Angiotensin receptor blocker might have some benefits to leaflet remodeling. As reported in one study, patients with functional MR, those taking ARBs or ACEI had a great leaflet area to close area ratio and thus lower MR severity. The role of Entresto, since HL endocrine failure might be addressed by blocking the neprilysin. So neprilysin inhibitor might restore AMP depletion, and as you can see in the HFpEF study, Paramount study, the LA size and the LA volume reduction is observed in the Entresto group after 36 weeks treatment. In the first study who proposed the atrial functional MR, despite having a moderate or greater degree of MR, patients with functional MR show significant improvement in valve function if once sinus rhythm can be restored. In the just mentioned the Cleveland TEE study, compared to conservative management, mitral surgery was associated with improved survival in atrial functional MR. But mitral surgery did not reduce heart failure hospitalization for atrial functional MR. In summary, atrial functional MR is a distinct form of type 1 MR that is underreported. Annular dilation, insufficient leaflet remodeling, and impaired mitral annular dynamics are the three major mechanisms for atrial functional MR. Due to different therapeutic needs, it is crucial to differentiate atrial functional MR from ventricular MR. And the first study is needed to provide more therapeutic evidence. And this is my presentation. Thanks for your attention.
Thank you, Dr. Huang, for the informative and interesting share and speech. I think now it's time for open discussion for Q&A from all the panelists and the participants. Personally, I think I have two questions for Dr. Huang. I think in your talk and your speech, you mentioned about the concept about the rhythm control of atrial fibrillation in heart failure, and I believe that Professor Chung-Lieh is also expert, a famous expert in this field. My question would be that so far we know that the rhythm control in heart failure preserved for those patients suffering from atrial fibrillation does not seem to have a very good outcomes compared to heart failure reduced ejection fraction with atrial fibrillation if we are going to ablate this patient by intervention. And do you think that the echo method provide useful insight to discriminate or to explain this condition, or you think that you have different viewpoint on this topic? And the second question would be about, you mentioned about atrial functional MR. For me, I think this is poorly defined in my daily practice, and would you recommend any useful marker for us, for our doctors, to discriminate atrial functional MR from other secondary functional MR clinically, that we can choose to have the most optimal treatment modalities? Thank you.
Thanks for your important question, Professor Huang. I think about the first question, it is actually very tough task to deal with the half path. Since unlike half wave, which is the most etiology is ischemic cardiomyopathy or dilated cardiomyopathy. In terms of half path, actually the spectrum is complex. It could be it could be the effect of diabetes, could be hypertrophic cardiomyopathy, and or other non-significant coronary artery disease. And atrial fibrillation is actually also a major cause of HFpEF, since as to in the HFpEF score, atrial fibrillation contributes 3 points in this score. So if we want to generalize this idea to all the HFpEF, I think it will fail. But if the atrial fibrillation is the major cause of the HFpEF, and there is the developed functional MR, I think the rhythm control can bring more benefit than we previously understand it. And as for the second question, how to define atrial functional MR from other kind of functional MR? I think an important thing is if patient is under atrial fibrillation, I think it is important to when we before we evaluate the mitral valve structure, maybe restoration of sinus rhythm is necessary, because the AF RVR can lead to the change of mitral annular dynamics, and this will cause some difficult to compare the effect of the treatment. So if we restore sinus reason, I think inadequate leaflet growth is one of important mechanism in atrial functional MR, and most ventricular functional MR is mostly secondary to myocardial infarction, and I think the distortion of papillary muscle will be more obvious. So there will be more, as I just reported, there will be more valvular tenting and the tethering. So I think it can be differentiated under a NICE-T examination. Thank you.
Thank you, Dr. Huang, for your feedback. I'm wondering whether Professor Sung-Jin Park or Professor Chung-Lieh will give us some comment or some idea about the questions or any feedback from the panelists. Okay, if not, I think we will move on to the next speaker. I am going to introduce Dr. Robin Augustine Flores, currently a doctor at the University of St. Thomas and the Faculty of Medicine and Surgery at the Philippine Heart Center at Philippines. I think he is an expert in the intervention and the cardiac catheter and also the cardiovascular functional imaging. So I think he is going to share with us a wonderful topic about the critical timing and the candidate of surgical or transcatheter treatment for severe tricuspid valve regurgitation, decision TR severity, or right ventricular pulmonary artery coupling damage. This is a very practical topic, and let's welcome Dr. Robin Augustine.
Good morning, good afternoon. So I'll be sharing my screen. Yes. There. Can you see my screen?
Yes.
Yes. Okay. So good afternoon, everyone. I'd like to thank APSC for this invitation to speak on a topic which is not quite often discussed, but will be quite important to some patients who come to our clinics. So this afternoon, I'll be talking about the critical timing and candidates for surgical or transcatheter treatment for severe tricuspid regurgitation. Is it a decision by TR severity or RVPA coupling damage? So I have basically nothing to disclose. I am a cardiac surgeon by profession, and I do have a master's in minimally invasive therapeutics from Scuola Superiore in Italy. So the objectives of this talk is to describe the incidence and classification of tricuspid regurgitation, as well as the methods of grading tricuspid regurgitation as we know it, to elaborate on the right ventricular pulmonary artery coupling, or RVPA coupling, as well as review the options for intervention for tricuspid regurgitation, as well, and lastly, to discuss the selection for patients for tricuspid valve intervention. So the tricuspid valve is often described as the forgotten valve, as we have always been focusing on the aortic and mitral valve, and so much study and analysis has come into studying the aortic and mitral valves, but tricuspid valve has been put in the back burner in general. Valve lesions in the tricuspid valve are usually insidious, and the symptoms present quite late. Right ventricular failure due to tricuspid valve usually results in poor prognosis, so this is something we want to avoid, and we want to deal with the tricuspid valve as early as possible to improve patient survival and outcomes. Tricuspid regurgitation occurs roughly in 0.5% of the general population, but this prevalence increases with age, and it affects approximately 4% of patients who are aged 75 years and older. Patients usually present with symptoms late in the course of the disease, and like I mentioned, patients usually present often with RV failure. Tricuspid regurgitation can be primary, caused by infective endocarditis, rheumatic heart disease, carcinoid syndrome, somatous disease, endomyocardial fibrosis, congenital valve dysplasia such as Epstein anomalies, and trauma. But if you focus more on the secondary causes of tricuspid regurgitation, which will be the focus of this talk, it may be caused. It usually is caused by left ventricular heart failure, myocardial dysfunction, left-sided valvular disease, and as well as a late development after prior left-sided valve surgery or intervention. If you look at the echocardiogram criteria we use to grade the severity of tricuspid regurgitation based on the 2021 ESC and the EACTS guidelines, we can see that the TR severity is still maintained as the major objective basis for tricuspid valve intervention using different qualitative as well as semi-quantitative and quantitative measurements. So for the semi-quantitative measurements, we use vena contracta, PISA, hepatic vein flow, and tricuspid inflow. While for the quantitative data, we use the EROA as well as the RV, regurgitant volume, as well as the enlargement of the cardiac chambers and vessels. Furthermore, it's suggested to use 2 additional grades such as massive and torrential tricuspid regurgitation, which has been described and is presently being used in clinical studies for transcatheter tricuspid valve interventions or TTVI. We know that there is a management algorithm based on the mentioned 2021 ESC and EACTS guidelines describing the management for severe tricuspid regurgitation. And we know that there are multiple options for management, whether it's tricuspid valve replacement or repair, or just purely medical therapy. We have read that there is limited benefit of surgical correction over medical therapy since this is not well established. But patients may benefit from early intervention, which may decrease the mortality as well as improve good long-term survival. We have to put into consideration here different factors such as RV size, tricuspid annular dilatation, to determine our decision and to see the benefit of the patient, whether to do intervention versus medical therapy. So when we look at right ventricular function, we look at the factors which could affect risk stratification and timing. So there is the so-called ventricular interdependence or VLV interaction as described by Rana and et al. In 2019, wherein the RV-LV interaction affects RV function. Of course, there is the RV ventricular size, which is a quantitative measurement. And as previously discussed by the other speakers, RV size is quite important in determining even the impacts of survival for mitral valve disease or left-sided disease, left-sided valve disease. Also, RV contractile function, which is determined by M mode, fractional area change, RV index of myocardial performance, as well as right ventricular longitudinal strain, can be a measure for in a quantitative way to determine RV function. Now, when we look at right ventricular or right ventricular pulmonary artery coupling, which is the sort of relationship between the RV and PA, the invasive measures have been the one that has been studied for this relationship of the RV and PA. So RVPA coupling is described as the energy transfer between the ventricular contractility and the pulmonary arterial afterload. Now, ventricular contractility is described as end systolic elastance, or EES, while the arterial afterload, which is the net vascular stiffness, is described as the effective arterial elastance, or EA. With these two values, there is what we call an EES-EA ratio, and the ideal ratio falls between around 1.0 to 2.0, as said by Su in his article in 2019. This invasive measure, which is the EES-EA ratio, it may be observed in early pulmonary hypertension because the RV thickens, and this is RV hypertrophy. So both the EES and the pulmonary arterial afterload increases, so the ratio is the same. But this ratio falls when there is RV decompensation. So when the EES decreases, the ratio drops. So it is also determined that when the EES-EA ratio approximately goes to 0.805, this is a best predictor of cardiac MR as an RVEF of less than 0.35, which is a usual cutoff in echocardiography. So when this ratio goes to 0.805, this can be a good gauge as to describing RV function as well. There have been efforts to determine the RV-PA coupling in an invasive manner. In a study by Todaro in 2020, they determined that the RV-PA uncoupling through echo may be useful in the diagnosis, prognosis, and the therapeutic guidance of patients with suspected right ventricular dysfunction. So one measure here would be the TAPSE, as well as the pulmonary arterial systolic pressure. So the ratio of these two, TAPSE over PASP, can be an independent predictor of invasively measured RVPA coupling. So which is quite important since this EES-EA ratio determined invasively can possibly be used as a last resort, and the TAPSE-PASP ratio can be used as a sole determinant of RVPA coupling. Furthermore, the TAPSE-PASP ratio may be associated with improved prognostic prediction of outcome. So also in a study by Tello and others, the TAPSE-PASP ratio, we're having a cutoff of 0.31 millimeters per millimeter mercury, was able to predict an RVPA uncoupling, which was, as previously mentioned, EES-EA ratio of less than 0.805. So going back to the TAPSE-PASP ratio, this is easily executable bedside and be used for early identification of the RVPA uncoupling, which definitely may preclude RV failure and be an early indicator of possible intervention for tricuspid valve disease. Of course, as a surgeon, I have to mention the surgical approaches or interventional approaches for tricuspid regurgitation. So surgery for isolated tricuspid regurgitation is not widely done, not just in the Philippines, but I guess in other countries, yes, even in the Asia Pacific. but despite the poor prognosis for patients with late-stage RV failure. And we have seen an increased use for minimally invasive valve surgery or minimally invasive tricuspid surgery, which may improve outcomes and increase survival for this subset of patients. We may also consider transcatheter tricuspid valve intervention for patients who may not be suitable for minimally invasive tricuspid surgery. So in a study by Abdul-Bar in 2021, the mortality rates for surgery for isolated tricuspid regurgitation by sternotomy can reach as high as 50%. But with minimally invasive approaches, the 30-day mortality can go down up to as low as 5%, even in this redo settings, as mentioned by Mayamati in 2017. And in his own study in 2021, Dr. Abdul-Bar mentioned that combined primary and redo tricuspid valve surgery, the 30-day mortality rate was 4.1%. Just as I go to my experience in minimally invasive tricuspid surgery, I had a patient who was an 84-year-old male who had occasional shortness of breath, persistent leg edema, but had a quite good functional capacity. He had a previous single-chamber pacemaker implantation 10 years prior. He already consulted with 2 interventional cardiologists in hospitals, but they said not be able to do an effective intervention for him. And my evaluation, he had a moderate clinical frailty scale, which was based on the Rockwood scale 4, which was determined to be the vulnerable stage. So I'd like to show this video of the involved tricuspid valve leaflet, where the pacemaker was sort of intertwined into one of the chordae. So we were able to put here through endoscopic means the tricuspid valve annuloplastering, the incomplete rib, and we were able to reduce that tricuspid valve, and the patient was stable post-op. But going to transcatheter devices for tricuspid regurgitation, based on the article by Dr. Goldberg from the US in 2021, he described orthotopic transcatheter therapies. And important things to consider here is the coaptation gap, the presence of previous ventricular pacing wires, as I had shown in my previous video, so that's annular size and shape, the angle of the inferior vena cava, which is important for the access for the transcatheter device, as well as the leaflet anatomy. Also, there are heterotopic transcatheter therapies, which is used not directly on the tricuspid valve annulus or valve. This is when the orthotopic technique is not an option. So there are multiple geometric challenges which preclude valve deployment. We have to consider valve RV hemodynamics, because the RV hemodynamics can will be important in determining the heterotopic transcatheter success. Furthermore, this technique reduces venous regurgitation and effects of RV failure, such as the anasarca and edema and hepatic congestion ascites, but this does not decrease the right atrial size, as these devices are usually implanted in the vena cava. So as you can, as in this slide, you can see the difference between the orthotopic transcatheter options, which is either in the annulus of the tricuspid valve or directly on the tricuspid valve. The heterotopic transcatheter therapies are placed in the IC, which may relieve the symptoms related to tricuspid regurgitation, such as anasarca, edema, and this is typically used with valve similarly used for AVI, which are implanted in the inferior vena cava. assuming anatomy is ideal. We use interventions for regurgitation. We usually look at options such as surgery or transcatheter techniques. Now, how would we choose? Use the item, it depends on multiple factors. The tricuspid valve severity, regurgitation severity remains the basis for decisions for management for the tricuspid prevention. We use the RVPA uncoupling, which is largely, although academic, but clinical use is not widely applied. And the possible value of the RVPA uncoupling as the initial gauge to consider intervention in patients with the severe TR may be possible before RV failure occurs. Again, the factors for choosing between surgery or transcatheter approaches depend on, of course, patient factors. Is it a primary procedure or secondary? So it's important to look at this because if there is already a previous intervention, maybe a transcatheter procedure would be more ideal. Another is symptomatology of the patient. Is the goal just for, will be just for validation, or will it be for long-term benefit? So that would be an important thing to consider. And another factor is overall risk. By determining Euroscore 2 or the STS risk stratification, we can see if this patient would be better for surgery or transcatheter. Next would be frailty scores using clinical frailty scale by Rockwood and other measures, maybe by Johns Hopkins or the Fried scale. Also look at life expectancy. So if this patient has a short life expectancy, we have to look at options that will benefit the expected longevity of the patient from the time of intervention. In summary, I would like to say that tricuspid regurgitation grading is still the existing tool for determining severity, but the RVPA uncoupling may be an early predictor for RV failure and may facilitate therapeutic guidance and recommendation for intervention. The individualized treatment for severe tricuspid regurgitation is very important. And when there is beginning RV failure, we should see our options, whether surgical or transcatheter. Before I conclude this talk, I would like to acknowledge Dr. Edwin Tukay as a contributor for this talk. He's the head of the training committee of the adult cardiology department of the Philippine Heart Center, as well as training officer for the non-invasive cardiology division of the same hospital, as well as he's also the immediate past chairperson of the ASEAN Society of Echocardiography. So with that, I'd like to conclude my talk. Thank you for your attention, and again, thank you for the invitation to share on this topic.
We thank Dr. Robin for the interesting topic about tricuspid valve regurgitation. I think it's quite practical a topic in our daily practice, and as we can see, some tricuspid regurgitation in heart failure or in heart PAVE or in more disease category spectrum. And now we welcome the discussion or comment or questions from our panelists.
So I have some question about this lecture. Thank you for your wonderful lecture about the tricuspid regurgitation. In clinical field, there's so many parameters, including clinical factor and the echocardiographic factor and the other imaging factor about the RV function. So in our hospital, we check the laboratory finding and echocardiography RV function and tricuspid regurgitation severity, and also we check the RV function using by the cardiac MRI. So some patients we check the right heart cath, and after that we check the intravascular hemodynamic proper parameters. How about your opinion? In clinical field, do you check all those of parameter, or is just a simplified selection of the candidate of tricuspid surgery, or is the intervention?
Thank you for the question. That's a very important point which you mentioned regarding further imaging for tricuspid regurgitation. The use of cardiac MR would be possibly the most important for me if I was to determine volume status of the regurgitation. Although the decision making to do that, if we look at the guidelines, maybe one of the factors only to decide if the heart team would decide if there would be an intervention to be done, then cardiac MRI would definitely be an important tool to help in determining. And if the team would look at possibly large regurgitant volumes, or look at how hepatic inflow would affect and counteract the cardiac MR findings in terms of regurgitation, then maybe this could also be an important factor in possibly making this patient be a candidate for intervention.
So another question about that is the current guidelines suggested if the patient has the severe pulmonary hypertension, so that time is the cardiac surgery, the tricuspid regurgitation surgery is not good candidate for the TBR or is the intervention. So in our hospital, we don't have the tricuspid valve intervention until now. So how about your opinion, if the patient have the severe pulmonary hypertension, but is the medically intractable and we don't have any choice, and what is the option for those patients?
Yes, that's another good point you raised, because the presence of an increased pulmonary artery pressure, which leads, of course, to the tricuspid regurgitation, may preclude intervention that would be available in the hospital or the medical center, because although you would want to, and like I mentioned, it depends on the goal. If it would be palliation to decrease the symptoms, or would it be a sort of a curative, or something in between curative as well as improving symptoms. So it would depend really on the target of the team, of the heart team, as to if the presence of the severe pulmonary hypertension would be something that can be overlooked, and look at more the effects of the procedure more on the palliation side, or either. So it would really depend on the discussion of the heart team and the goal for the patient.
Thank you.
Thank you.
Any further questions from our speaker or panelist? What about Professor Chung-Lieh or Professor Adisai?
Actually, I would like to thank Dr. Flores for a great presentation. One of my questions, maybe I would like to share my question to our panelists as well. What is the cut point of the pulmonary pressure that you think that it would be have a significant effect on the tricuspid regurgitation, because many patients who having the tricuspid regurgitation also have the pulmonary hypertension. But what is the cut point that we should not perform the tricuspid intervention if the pulmonary hypertension exists?
Yeah. So I would say that thank you for the question. I would say there would still be a little bit of a gray area, if there is such a thing for that, because even if there is pulmonary hypertension, let's say if you're talking about pressure of around 60 millimeter mercury, you would still have to look at other things in the RV? Would there be a contractility effect of the pulmonary hypertension? And maybe look at also, would there be also another underlying problem for this patient? Would the pulmonary hypertension be a primary or secondary from a mitral valve disease on the other side? So I would say that it would be an important thing to consider, but determining a really cutoff for the pulmonary hypertension could be a secondary thing to consider. But maybe the relationship of the pulmonary artery pressure to the RV function would be something more, I would think, more to consider, and look at if you would really want to look at whether a surgical or transcatheter intervention. And like I said, I think it's a gray area, and I think that there is no hard and fast rule for this. So I think it would be a clinician and a heart team's choice for that. Thank you.
Thank you very much.
Any comment or any question from our panelists or participant?
Dr. Huang, your microphone is muted.
University, and I think I would like to share and express my gratefulness for all the speakers and the wonderful topics shared by 4 famous speakers, about from Professor Adisai, Professor Park, and Dr. Huang, and Dr. Robbins. It's brought into the insight of different heart topics about valvular heart disease and structural heart disorders. Our program is actually supervised by Professor Chung-Lieh from National Taiwan University. He's also the senior and my teacher in this field. And finally, I would like to share with everybody about the disclaimer from our APSC webinar today. The content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinion expressed in this webinar are those of the faculty members and do not necessarily represent those of the APSC. And the housekeeping message is that the live streaming content of this webinar will be made available via APSC Cloud, APSC Facebook, and the YouTube page. And I think I would like to say that today we have a lively discussion, and we have an in-depth discussion about structural heart disease and valvular heart disease from all the experts who shared actually the very practical viewpoint and some very wonderful lectures. And I think we are going to close out today's webinar. Again, I would like to thank all the participants and all the panelists and the speakers for today's meeting. Thank you all. Thank you.
Thank you.
Thank you all. Thank
Goodbye.
you. Goodbye.
Thank you very much.
Thank you.
Bye.
Thank you.
Great to see you all. Thank you. Bye-bye.
Bye-bye.
Okay.